You can see it, eh? Perfect. Okay, cool. So we know that there is these various types of cartilages, and we are chasing the hyaline cartilage. That's what we want to replace cartilage defects with. And unfortunately, most of the healed defects turn out to be fibrous cartilage, which means very few cells. And the collagen is a different collagen. It's not really arranged in the same way, and that's why it's suboptimal. And just to recap, the cartilage has got these zones, the superficial zones. The fibers are basically parallel, and then the transition zone, they start to basically through the deep zone, and the tight mark start to anchor into the bone. And the tight mark is really the most important layer when it comes to the injury of the cartilage, because that determines whether the cartilage injury is superficial or deep. And it also determines how the cartilage injury will heal. That is also something we know, that the function is to absorb shock and to decrease some friction in the joints. And that the cartilage gets its nutrition mainly through the synovial fluid, and by basically pumping fluid through movement in and out of the cartilage, it does live. So unfortunately, it's avascular and has poor repair characteristics. And the most useful classification for cartilage injury is the ICRS, so the International Cartilage Repair Society. And what you'll see with most of these classifications, mainly that it's those deep lesions that differentiate between when the lesion is crossing the tight mark and when it's actually not crossing the tight mark. And that's usually, grade 3 or grade 4. Same with the outer bridge. It's again, whenever the tight mark is crossed and it becomes a full thickness chondral wear with exposure of subchondral bone, and that's when we realize that the cartilage will heal differently, and that's where, that's actually the most important point of this classification. So what happens when the tight mark is not crossed is that there's no chondrocyte migration to the defect. There's no real cartilage that's formed, even fibrocartilage, because there's no hematoma, and that's why the cover of that cartilage defect is poor. With deeper cartilage lesions, you get a clot formation. That clot releases growth factors, and fibroblasts generate collagen, and it then forms a stronger scar tissue. So that's the main understanding, or I think that's the main points about understanding cartilage defects and their depth. So how do we treat them? We can either just debride them. Cartilage flaps can be debrided, and we can do a chondroplasty, which is not really something that will stimulate new growth. It's just something that so you prevent flaps of cartilage moving in and out of the joint and maybe causing locking. But the differentiation of cartilage repair techniques can be made by looking at marrow stimulation techniques, which basically means that you drill holes or punch holes through the tidal mark into the bone, and then you'll get a clot. And that's actually a good way to get in sportsmen, for example, to get about 5 years out of them. So football players, you do that, you get 5 seasons, and after those 5 seasons, their outcome scores and their pain levels, the outcome scores will drop and their pain levels will rise, and you'll basically come to the end of the life of that knee in terms of sports. But it's very cheap and it's very easy to do, and you don't need a 90-degree access to or a perpendicular access to the surface of the cartilage. And also in private, especially in South Africa, we only really have 1 or 2 codes that can describe cartilage repair. And so it's much quicker and easier for you to do a microfracture and build the same code as to do any of the other techniques. So a lot of it in private and in state, and a lot of the go-to method is basically this microfracture. Then the osteochondral autograft transfer, or OATS, is another very good way to address cartilage defects with the same tissue. And it has basically, out of all the cartilage repair or cartilage restoration techniques, the best histological picture and also the best outcome for certain sizes of lesions. So it's got a 90% good outcome at 10 years. The athlete can basically play at least 10 years instead of 5 years. So for young patients with active lifestyles, a very good option. Although you need 90 degrees of perpendicular axis because you need to put those bone plugs in to the joints. It's difficult in the tibia, for example. You have to do that retrograde. And it also doesn't work as well in the patella, mainly because the patella cartilage is very thick, and all the other cartilage that you harvest usually doesn't have the same thickness, and then you get pressure on that area, and it just doesn't have the same outcome as, for example, for the femorocondyle. So that's why it's ideal for the femur, and then so-so for the tibia, and not so great for the patella. Also, when it becomes bigger, cartilage defects like more than 4 centimeters square, you get donor site problems because you have to harvest the cartilage from somewhere, and eventually you run out of graft. So that's basically the 2 techniques that we use most commonly, the microfracture and the OATS. Because it's available, it's cheap, you can use the patient's own tissue. In private, unfortunately, you can't bill, or say Discovery doesn't pay for OATS, they only pay for microfracture. You have to really motivate to do OATS, and then it takes longer and you get the same money. So most people actually kind of shy away from it. Then another step up of microfracture is this autologous matrix induced chondrogenesis. Basically, it's just a membrane that you, after you did the microfracture, you put over the defect, so you get a super clot. Basically, the synovial fluid can't now take away the clot, and you get a better clot formation. Sometimes also overgrowth, which is a problem. But overall, the technique is not really that much better than microfracture. Autologous chondrocyte implantation is the next important technique for larger defects. So when you're talking about defects that are more than 4 centimeters, it's got a very good it's a very good way to treat those defects, especially in the young patients. So young, we're talking about 25 and younger, very good outcome between 25 and 40 years. So it's still a good outcome. And then after 40 years, the outcome doesn't, for some reason, the chondrocytes aren't as active, and it doesn't give you as good an outcome. It is affected by second stage surgery. So if you did a microfracture beforehand and then you do an ACI afterwards, the outcomes aren't as great because there's obviously some inflammation in the joint that starts to develop. The negative sides of this technique is that you have to have a 2-stage. It's a 2-stage procedure, and there's a small arthrotomy that you usually do. So initially what they did is they harvested the cells, they send them to a lab. The lab is somewhere in Europe. And then you get this fluid back with some cells, and oftentimes you don't know how many cells there are. Various labs generate various cells. You take that fluid and you inject it under a periosteal let me just see. So you injected under a periosteal flap. Then there's that flap also, the periosteal flap also generated a lot of hypertrophic tissue. So it's almost like forming a little bump there now. So then they decided in the second generation, wait, let's not take a periosteal flap, let's take a porcine membrane. And they still had to stitch that membrane on the cartilage. And so some of the cells that were injected underneath that membrane got lost. And so they decided, let's take a matrix and then embed those cells into the matrix. And that's where the matrix associated ACI or MACI comes in. So that's what we're talking about. And then the allograft, unfortunately, so that technique in South Africa is very costly. And you have to get those cells, you have to send those cells to Europe and then get the cells back. Some surgeons basically try to circumvent that, take cartilage out the joint, they grind that cartilage up, take a fibrin glue, put the cartilage back on the knee during the same procedure and put this fibrin glue on, and in a hope it kind of generates the same effect. The allograft in South Africa, unfortunately, the allograft in the States is massively used because they can get fresh allograft that's not treated with radiation, and it's got very good healing potential or ingrowth potential. But unfortunately, in South Africa, that's not possible. So the allograft is irradiated here, and it has got a poor, it's got poor outcome overall. Are there any questions to this? For now? Did you guys hear this all? Talking into the dark. Okay, cool. So I'll go on. Maybe just one guy or one participant could maybe give me feedback if you guys are all happy with it.
Yeah, it was good. Thanks, Prof.
Cool, perfect. All right. So let's go to the meniscus. Also very short. This is the cases. Okay, so this is also very short, like 5-10 minutes. Let's see. Meniscus there. Okay. Okay, cool. All right, so you see that?
Yes, Prof.
Yeah. Okay, cool. So let's talk about the anatomy quickly, just to recap. The meniscus has got a C-shaped lateral meniscus, sorry, around a circular-shaped lateral meniscus and a C-shaped medial meniscus. The posterior roots of that meniscus are attached about 1 centimeter of the lateral meniscus are attached about 1 centimeter from the attachment of the PCL. And then between the PCL and the posterior root of the lateral meniscus, you've got the root of the medial meniscus, the posterior root of the medial meniscus. Remember, the lateral meniscus has got 2 ligaments that insert into or around the PCL and the femur, and that's the ligament of Humphrey and the ligament of Risberg. Humphrey in the front, Risberg in the back. In the anteriorly, that lateral root of the meniscus is underlying the ACL. The ACL is a ribbon-like structure, and it overlies the lateral root, the anterior root of the lateral meniscus, which is important when you drill the ACL tunnel. Because you don't want to drill the ACL tunnel if you have an ACL, associated ACL injury. You don't want to drill the tunnel into the root. You also see there's a ligament between the 2 menisci. That's the intermeniscal ligament. And then you can just see the shape. The lateral meniscus is nice and broad, and it's not connected to the connected to the capsule, whereas the medial meniscus is a bit narrow shaped, and it's attached and connected. It's attached to MCL, and it's got reticular fibers that are connected to the tibia. And that's why when you lose your ACL function, then the lateral meniscus and these attachments, the medial meniscus and these attachments start to give you the resistance to anterior translation. And that's why oftentimes in chronic ACL injuries, you get medial meniscus cartilage, medial meniscus wear and damage. The collagen fibers are lined longitudinal, and those are the most important fibers because they're now anchored in those two. So those longitudinal fibers are anchored in the roots, and they go all the way through the meniscus. And those are the fibers that when you step on your knee, those are the fibers that prevent the meniscus from being pushed out of the knee. And those fibers are then bundled with radially aligned fibers. Also, this is a nice Anotsky's stain, quite famous for showing that most of the vessels are in the peripheral part of the meniscus, and there's almost no vessels in the central part or in the inner part. And also the makeup of the meniscus, you have these fiber-like cells, fibroblast-like cells on the peripheral part, and then they become chondrocytes, and then in the end, on the inner part of the meniscus, they're almost cells of a transitional zone. So they're not really taking part of cartilage generation. Remember the meniscus until age 10. That meniscus at age 10 is completely, or up to the age of 10 is completely perfused. And that's why meniscus tears in children heal a lot better. But after the age of 10, slowly those vessels are starting to retract, and in the end just lie in the periphery. You use it to absorb shock, to transmit the load of the weight that you put through the knee for stability, like we said, especially in the medial meniscus. And also with those ligament of Humphrey and Risberg, part of the lateral meniscus gives you stability to posterior translation. It almost acts like the PCL. If you cut the PCL and you look at the ligament of Humphrey and Risberg, they actually take over the function of the PCL. They lubricate and provide nutrition, and they're also used for proprioception. So in the end, when someone steps on the meniscus, that force is translated, and you create hoop stresses, and the hoop stresses resisted. The longitudinal fibers and the meniscal roots resist those hoop stresses, so that the meniscus isn't pushed out. And they're basically anchored on those roots. What happens if you don't have that? Then you get point loading on the meniscus, on the cartilage, and eventually you get a lot of load on a very small area of cartilage, and that gives you osteoarthritis. So these are images, biomechanical heat maps of pressure. And you can see that with an intact meniscus, this is how the medial and the lateral meniscus looks like here on top. And then with a root avulsion, it gives you almost the same picture as with a radial tear in terms of the heat map. So that it becomes a lot smaller, the area of contact, and a lot more contact. So in essence, if you have a root avulsion, if you have a radial tear, that's bad for your meniscus because for your cartilage, because it increases the contact stress and it decreases the contact area of the two femoral and tibial cartilage, because the femurs around the tibia is flat and you need some structure in between to give you congruency. We know these various forms of tears. What's bad is, like we said, radial oblique tears, and what's good for healing and also for these hoop stresses is these very vertical or longitudinal tears. And associated ACL injuries, most of the time the lateral meniscus is injured in acute injuries, and in the chronic injuries, mainly the medial meniscus, because it does give you this restraint to anterior translation if the ACL is gone. How do we manage them? It's a very contagious topic, or it's a very hotly discussed topic, because it turns out meniscus surgery is the bread and butter. It's the most important or most commonly performed surgery in orthopedics. So a lot of guys in private are using it to make money. And so the orthopedic fraternity is very slow to change debridement, meniscal debridement. But it turns out that most, and we speak about that later as well, most associations recommend that degenerative meniscal tears should not be treated surgically. Also, in a younger patient, meniscal tears give you better long-term outcome, and they give you better clinical outcome, and they give you less osteoarthritis in the joint. Various techniques, inside out and all inside techniques, have the same outcome. And then these biologic augmentation strategies, the recommendation is not very clear. And also on the postoperative protocols. There are mainly 3 different ways to repair meniscus: inside out, outside in, or all inside. The all inside techniques, you're taking a needle and you're putting that needle into the joint and you're trying to repair the meniscus. And so wherever you can't reach with that needle from an anterior portal, it's difficult to repair the meniscus. So with that technique, it's easiest to repair the posterior roots, the posterior horn, and as much of the pars intermedia as you can reach. But as soon as you go to the anterior part of the meniscus, like here, it's very difficult to reach that with an all inside needle. So the anterior part of the meniscus is almost only really accessible to inside out techniques, where you push a needle through the meniscus, like you can see here, through the meniscus, and you draw out a suture, and you can suture it over the capsule. And then the main thing about the inside out technique, which is this technique here, is to make sure that you protect the posterior structures like the common peroneal nerve or even the arteries that run in the back of the knee, to make sure that you're not putting that suture through one of these structures. But these needles can be used very similar, so that the inside out can be used very similar to the all inside, except it's a lot cheaper. And then there's various complex tears that it's a good way to know, or it's important to know them, especially if you're writing your exams. And that's the root tear. Yeah, so a root tear you can repair, and the best way to repair root tear is actually through a transosseous suture. These transosseous sutures can also be used for big radial tears of the medial meniscus, like you can see here. And then the ramp lesion is basically a disruption of the capsular attachment on the medial meniscus, on the posterior horn of the medial meniscus. Very difficult to see from the front. When you look into the knee with a scope, oftentimes you can't really see it nicely. You have to push your scope into the posterior medial compartment to be able to visualize that and to be able to probe it. And so it is often not seen. On MRI scan, very difficult to see. And also when you're scoping, not easy to see. So oftentimes this lesion is overlooked. And that's mainly the thing that you need to know about ramp lesions. So complex tears, some of them are root tears, transosseous fixation, and ramp lesions. In terms of the post-op treatment, I would say this is a very simplified way. The knee immobilizer, so you don't want to have so when you bend the knee more than 90 degrees, the condyles start to drift a little bit back on the tibia, and it does give you a bit more pressure on the posterior horns of the meniscus, and especially for radial tears or root tears, that's bad, and especially if you load them in flexion. So that's why most surgeons would restrict active and passive range for about 6 weeks, and then load inflection for about almost 3 months. Weight bearing, people are a bit more lenient. And, you know, basically anything between non-weight bearing to touch to partial weight bearing between 0 and 6 weeks. That's it. Guys, have any questions? No questions. Glad to see so many participants. 26. How? 23. So it's 22. So it's almost everybody, huh? Quite impressive. Okay, guys. So I want to see some faces now because I'm going to ask some questions. If you don't have your face on, I'm not going to ask you any questions. If I don't see anyone, and I'm going to just stop because I'm basically just speaking to the web here. Okay, Mike, John. Okay, cool. Thanks, guys. And just keep it on. Keep it on. If you need to pick your nose or do something, you can quickly turn it off. But then I need to see your faces. I need that interaction. Okay. So what I've done now is I've made some cases, and we can chat about these cases and chat about a little bit more detail. And we can just run it for another half an hour or so. And if you have questions yourself, you must ask me, or ask your colleagues. Okay, so you can see that now. Let's see who I see. Michael. That's the easy case now. This is an easy case. So you've got this 18-year-old soccer player. Let's make it a rugby player. We've got this 18-year-old, how old is she? 19. The 19-year-old rugby player that's coming to our clinic tomorrow. And she's had this injury. She twisted her knee. She's a Western Province rugby player. She injured this knee a year ago. She's playing on, but she's not feeling very happy about it because it's clicking and it's painful. And I'll show you an MRI scan. I want you to basically describe that MRI scan. And then when we see her in the clinic tomorrow, because we're going to see her in the clinic tomorrow, Mike, I want you to tell me which tests you would do. And obviously the MRI scan we have already. I want you to tell me what do you think about sensitivity and specificity of that MRI scan, and then describe that anatomy. So what do you see here, Mike? Mike, just turn up your volume a bit. Can you?
I'm not sure how to do that. I'll try.
Maybe it's just me. Let's try again.
Can you hear me now?
Yeah, can the others hear you? Peter, can you hear
No,
Mike?
your sound is very weak.
Okay.
Hang on a second.
It sounds very weak. Mike?
Okay, I turned it up to 80%. How's that? Can you hear me now?
You know what?
I'm at max.
Yeah, it's a little bit better. Okay, so what do you see?
Okay. So, as I said, it's a sagittal cut T2 weighted image. The obvious lesion is what's called the double PCL sign, keeping with the bucket handle meniscus tear. So it's a pattern-in-one sign of a bucket handle.
Perfect. So we're in the notch. In the notch of the knee.
The anterior part is the bucket handle. The posterior part you see is the PCL.
Yeah, perfect. So for everybody, there's a PCL sign. There's a PCL here, and so you're in the middle of the knee, you're in the notch. So you shouldn't see another structure here. You shouldn't see anything in front of the PCL. You should maybe see the ACL, but the ACL doesn't run like this. So you'll see this structure here. That's basically must I mute you, Mike?
I'll mute me, hang on.
No, someone. Anyway. So there's like is it my baby? Oh, one of my babies. John, is it your baby? Yeah. Well done. Beautiful. But
Thanks, Prof. Keeping me
she's
busy.
sleeping.
Only 5 days old, Prof.
Oh man.
She's very interested in this double PCL sign. This.
Yeah, I'm sure she must have fallen asleep. Well done, eh? Congratulations. Okay, so this is a double PCL sign. What do you think we must do with it? Sorry, how do you, Mike, what's the test that you do for her?
So there's a couple of tests described for meniscus. The most sensitive is the fallacy test. If you can do it, get it to stand on one leg, axial load the leg and rotate internal external rotation. Ask if they get any instability or catching or locking, maybe a little bit of pain. Other tests that are described is the Atkins grind test and the McMurray test. I'm not sure about the sensitivities of those two.
Okay.
And yeah,
Good.
that test and joint line tenderness is considered as a sign the most sensitive.
Yeah, good. So there's symptoms, and when you assess the knee, you can look for various symptoms, and there's specific tests. So the symptoms, especially in a knee with a meniscal tear, is an effusion, pain and effusion. And on history, you'll have catching, locking, and they feel like there's a subjective giving way. It just means that whenever they have pain, they try to protect their knee, and in a quadriceps basically, or their knee gives way because they don't want to load the knee, and they feel as if it was giving way. And you often, especially in this in these meniscal tears, you get locking, and the locking means that the terminal extension is decreased. And then you can see here the various the specificities of the tests. And like you say, the Thicily test, they're all more or less the same. But it turns out that the joint line tenderness, if you have joint line tenderness and you've got an effusion, you actually don't need to go further, because you know now a joint line tenderness has got sensitivity of 80%, and you won't really beat that with any other test, except that you're going to make the patient painful. So if someone doesn't have pain when you feel the joint line, then it's worth doing these other tests. And the easiest is the Thicily test, because it does give the patient time to or the chance to control movement himself or herself. And then McMurray's and Upley's test, you're obviously doing it, and you can hurt the patient potentially. In the MRI scan, these are rock curves. That just means that whatever is in the top left corner is really good in terms of sensitivity and specificity. So it's basically almost at 1. So we're talking about 90% sensitivity and specificity when you're looking at the MRI scan. That was a clear meniscal tear, but if you have radial tears or tears that are undisplaced, then you're looking for this sign down here. Freddie Fu and Chris Hana, they're both from Pittsburgh. And in 1994, they came up with this classification of meniscal signs on MRI, meniscal signals on MRI scan. And the main thing is that you classify a tear on MRI scan as being a tear when there is continuation between the fluid on either side of the meniscus. So this is another, well done, Mike. So this is another case. Let's go from the top down. Aik. How are you, Aik?
Yes, Prof. I'm okay. Can you hear me?
Yes, I can hear you very well.
Yeah, thank you very much.
Okay. Aik, I want to tell you this. This is a case that I got. And Aik, this is a lady. She's a 67-year-old lady. I want to show you this. It's been referred by the spine team. She's 4 months post low energy injury while she was dancing. This is her 1936, and this is another time that they referred to me. She's diabetic hypertensive. This is Dr. Patel's email saying that this deputy head of this health department. So who's the background? Is that you, Aik?
No, there is some background from my side.
Okay, someone has got Asked to mute. I don't know who it is. Anyway, what language is that? What is that?
Hello?
It's Zimbabwe. Is it, what is it? That's Zimbabwean. I know this language.
No, Prof, it's not Zimbabwean. It's
Hey?
it's not Zimbabwean.
Is it?
No, no.
Okay, so I'll unmute. Well, why don't you guys mute all of you except I can't do it from my side. Sorry, guys. So it's obviously one that's not listening. Okay, let's see. So there's a lot of pressure for me to see this patient in my clinic.
Yes.
Fuck. So this is a MRI scan. It says, oh, there's an X-ray. Just tell me what you see on the X-ray.
So on the X-ray here, I got 80 of the knee X-rays. So what I can see here, there is some kind of degenerative joints here. There is a decreased medial side joints, and there is osteopenia. The bone is a little bit less osteopenic.
Yeah.
And maybe there is some kind of sclerosis and some kind of osteophytes there. And and some kind of cyst on the
What would you
joint.
do, Ayib?
So these things is keeping with degenerative osteoarthritis.
Yeah. So what would you do?
What I would do, I would examine the patient, and then for the first time I see the patient, so I would go for conservative management first. So see the patient, examine him, and
when would you operate, Ayib? When would you
I would operate on this patient if the patient got a really terrible pain after I exhausted.
Very bad pain.
Yes, after I exhausted. Yeah.
He's got so the pain is so bad that this email is coming from the head of office of the Western Cape, the boss of Bhavna Patel.
No, I won't consider that. I must examine the patient myself.
Oh, okay.
So, and then the pain must go with the clinical and with the X-rays and the patients. So looking into this knee, it doesn't look like it's a really bad knee. So still there are some space there. So
there is some space, there's some joint space there, right? So she's got pain, she's got meniscal tissue like this that's macerated and it's catching in her joint.
Yeah.
So that's the main problem why she's got pain, but there's still good joint space. So meniscal debridement will not really help us as much. And you can see this is a very often quoted publication in the New England Journal of Medicine in 2013, where they had two groups of people. The one, they just did this arthroscopy, and then they closed, no, they did an arthroscopy, they debrided the meniscus, and in the other group, they just put skin incisions. They didn't even do an arthroscopy. And you can see these are the pain scores and the outcome scores, and they're almost all exactly the same. So this was one of the landmark articles that went against degenerative meniscus tears being debrided. And subsequently, all of these AOS, NICE guidelines, the British Orthopedic Association, the American Orthopedic Association, all of these associations have come up with suggestions, and basically all of them are against this patient with radiographic osteoarthritis having an operation. Without radiographic osteoarthritis, some of them are for. And especially when the patient's got mechanical symptoms. So if you ask this lady now, when you move your knee, do you have catching or clicking? And is that clicking sore? Is that clicking giving you stabbing pain? that is potentially an indication that after conservative management of 3 to 6 months, that you could consider doing a debridement. Although in the most recent, in the MAGIC project, where they looked at all of this, but there's a lot of public health people in this project. It's a strong recommendation against any meniscal surgery for degenerative disease, even with mechanical symptoms. So I think the main thing is here, treat patients conservatively. After 3 to 6 months, if they still come back to you and they've got a clicking and locking that's painful, you may consider it according to what resources you have available in terms of theater time. Okay,
Prof,
yeah.
Prof, may I ask a question, please?
Yeah, of course.
When you talk about conservative treatment for menisci, what do you mean?
You tell me. Or you can find a friend that can tell us. This is an exam question. And we're from the top down. Nico Putman. Sorry, you have to unmute yourself, Nico.
I'm here.
What's the conservative management of meniscal tears? Degenerative meniscal tears.
Degenerative meniscus tear. I use a mnemonic in which so let's just quickly from the start, it's lifestyle modification. So you'd ask the patient to change the, exactly like Michael said, the Allen Poppy. Lifestyle modification, change the movements that will cause pain. Assistive devices not really indicate unless it's associates the instability. So let's not talk about that. Analgesia in the form of paracetamol, anti-inflammatories, and even severe cases of opioid of some sort. In the acute, if there's an inflammatory component, you can even include intra-articular steroid injections.
Okay, so
but I think what is important will be physio, specifically working on muscle strength in your quads or hamstrings if you've got an associated cruciate injury. Depending on which one is injured, that muscle group will be.
Degenerative meniscus tear. These patients usually don't have an ACL tear. Often it might be.
Well, like you say, the medial meniscus it's degenerative and can have an ACL, but I take the point.
Bayanda, it's symptomatic treatment mainly. So
Okay.
it's analgesia, and the braces, the medial unloader braces, are also symptomatic. It doesn't have great evidence. The only thing that really has evidence in degenerative meniscus disease and early arthritis is non-steroidals and physiotherapy. Everything else is obviously recommended, but it doesn't have great evidence. The AOS guidelines recommend that injections in the knee, steroid injections in the knee, should be given to patients that want it. That's the recommendation. But it doesn't actually have a great deal of evidence. All the other things, the PRPs and all the other injections are also not in the bigger trials, in the randomized control trials, have not been shown to give any major difference. Although people do it because it doesn't hurt, it might help, and if you're in that, because these patients are between a rock and a hard place, you don't want to operate on them, but they want something done. Many of the Cape Town surgeons try to kind of keep them and entertain them with PRP injections until they are ready for the joint replacements. So although you can't charge a lot for your PRP injections, people still do it because they hope eventually those patients will stay with them for the joint replacement. Okay, well,
Prof, sorry to harbor on this point, but my concern and my problem is the physios are going to ask you specifically, what do you want? So we know, I'm going to go completely left field. We know with patellar dislocations, recurrent patellar dislocations, they may have VMO weakening. So we will, when we refer to physios, ask for VMO strengthening and things like that. Biomechanically, what is the physio going to do for a meniscus injury? Because
you're mainly trying to keep the range of the knee. That's the main thing.
Okay. All right. Thanks.
The capsule starts to contract over time, and then you get a stiff knee, and it, you know, in the end that decreases. That becomes the knee that we then see in 5 or 10 years down the line. That's got a lower range, and that's the main thing. Is trying to preserve range, but doing that without putting strain on the knee.
Okay. Thank you.
And so in the end, you know, they'll pressure us to operate, and you have to resist that pressure, because in the end they're looking for an answer, and you are not the answer. Basically, that's what you have to they have to realize. Okay, so next one, Yapi, 25-year-old rugby player. This is a month after the injury, and you can see this. Just have a look at this tear and just, you know, describe what you see here.
Right, so just looking at this coronal site, coronal cut from the beginning, so you can see it's firstly on the femoral side, on that condyle, you can see that there's a hyperintensity, which would suggest maybe a bone bruise or bone edema there, like noted there, as well as which looks like a radial tear there on the meniscus on that side. The go sign there would suggest that there's some fluid collection just underneath the posterior horn of the meniscus, underneath the PCL. And just looking on this axial cut as well, fluid collection at the back, which would suggest, or what I would suspect, is a posterior horn injury to that meniscus.
That is the posterior horn here, but the defect is almost beyond that horn. So you basically, you can see this meniscus is extruded. You're right. Somewhere the longitudinal fibers must be torn. Otherwise, the meniscus, when you step on the meniscus is pushed out of the joint. So then you can see this is anterior to the PCL. There's no tissue here. It's a ghost sign. And you can see that there's this defect here. So that's what you call a root tear, posterior root tear.
Yeah.
So what happens? What's the outcome of non-surgical management here?
Well, it's a 25-year-old active sports guy. So, I mean, the moment, every time you're going to load that condyle on that meniscus, you're going to just extrude it from the joint. So you need to secure, maybe just go and repair or reconstruct that posterior horn using a bone tunnel.
How do you do that? Repair?
Well, you can do a osseous bone tunnel and just secure it down there.
Perfect. So that's basically what happens when you do that. When you repair, this is a biomechanical 3D graph of pressure over a certain area of the cartilage. So we can see where it's, the peaks of that, that's what the pressure is. And you can see the footprint of that mountain, that's the area. So there's an intact meniscus, there's a lot of area and not very many peaks. When you now have a meniscal tear, then you get one big peak and no more area or very little area of contact. And then when you repair that meniscus with adequate root repair, that means that you get almost the same picture as with an intact meniscus. So it is a devastating injury for a joint that gives you 100% osteoarthritis in 5 to 10 years. But if you address it, it gives you almost a picture as if the knee was intact.
And I just asked Prof, is the do they have? What's the chance of healing?
So what I heard now, your sound isn't great, but what I heard is that you wanted to ask whether it is in the white or in the red white or the red red cell. Am I right?
Yeah, that's it.
Yeah. And when you see the root basically is torn throughout all three zones, but it's torn literally at its insertion. So as the meniscus inserts into the bone, that's where the tear is. And obviously, you're right. It's a problem for the inner zone, but we try, because of the transosseous suture and also what we do, and I'll show you a quick video. What we try to do is actually, because we're too close to the bone there, is we're trying to generate bleeding by manipulating the cartilage in the bone underneath the roots to be able to generate healing through clot formation. But it's a good question.
Right, Michael. I just want to ask you, for the previous patient, Bayanda asked, did she fail conservative management already?
Yeah, no, we different. That's a different. So this is a different case, eh? So we finished this case.
Yeah, the previous one, yes.
So this is a 25-year-old drug replacer. It's not anymore that older patient anymore. But you're right. What would we do in someone with a root tear in an older patient? We actually, people are moving towards repairing that root, because they can get more.
Michael, I was asking about the previous patient, that older lady.
Yeah.
The previous case by Anda spoke with you. That one, yes. When would you consider doing a replacement for them? Would you do a uni or a full replacement? How long after conservative management? It's only a medial condyle affected from this.
Yes. Okay. So we're talking about now. This is not about meniscus surgery anymore, but
yes,
about joint replacing or joint preserving surgery. So arthroplasty or osteotomies. In a nutshell, there's obviously pros and cons to both, and there's also contraindications to both. But in someone that doesn't have bone-on-bone arthritis, so in this case, she doesn't have bone-on-bone arthritis, she's not going to do as well as someone with bone-on-bone arthritis. So the development of the uni knee in Oxford actually have that as almost as a yellow flag. Is if you don't have bone-on-bone arthritis, you should be very careful with doing uni knees. And some people in private and in Cape Town, when you have access to MRI scan, you look for bone bruising and you kind of justify, look, she's got some bone bruising, let's still do the uni knee. But in essence, she wouldn't have as good of an outcome if she's still got some cartilage left there. And for HTO, articular osteotomy, in her age, you know, the HTO does very well in a male patient that's like 50, 55, 60 active, good healing potential of the bone, no osteopenia. So you're basically, with this lady, you're a little bit stuck because she's not ready yet. She's not ready yet for for either the meniscal debridement. It's not going to help much. HTO, you might run into trouble, bone healing, osteoporosis. We know that all the ladies don't do as well as younger male patients. And again, her arthritis might not be progressed enough. But eventually you make the decision, and I would probably go for a uni knee. Okay, can we go on? So it's a difficult question. In an exam, you just be ready to discuss all of these things with pros and cons and with contraindications and with your approach. And the main thing is to make sure that you're not too aggressive in your surgical indication. Okay. So we got this root now. We're figuring out, should we do root repair or meniscectomy? We know that the repair is a higher reoperation rate, of course, because, you know, if something is still sore, you'll say, oh, maybe it's the meniscus repair that didn't work. In repairs that are not repairable, you should preserve as much meniscus as possible. The failure rate of repair, that depends on age and activity, is between 15 and 40%. It's a lot. And it's so difficult to actually know when has the meniscus failed, because if you do an MRI scan again in a couple of months, you won't be able to see if the meniscus is healed properly, because there'll still be some signal around the meniscus, and you don't know, is this now scar tissue, or is it that it didn't heal. So often people just actually, after 9 to 12 months of pain, they just go in and do another a scope, and then often at the second scope you do a lot less debridement that you would have initially done. So some of the tissue does heal. Okay. So what's your treatment for this? Remember, these are the roots in the back here. So you need to just understand the anatomy. And then, so what we do is, this is the root that's torn. You can pull it forward. So that meniscus, when the patient steps on that meniscus, that yeah. Okay, so that's the root. I can pull it forward. If the patient steps on that leg, that meniscus is going to be pushed out of the joint. Now we scrape around that area that, you know, Yapi, that's what you were saying, or Michael, that's what you were saying, is you're trying to freshen that bed for that root, trying to freshen it up. Now we're looking for the right point. And now we're putting through some sutures, and then you pull that root down and in. So that's a root repair. Postoperative management is basically the same as we discussed earlier. Trying to limit the range for about 6 weeks, and then loaded flexion for about 12 weeks. And don't really want to want this patient to walk on the knee for about 4 to 6 weeks. Okay. I want to ask, who will I ask? Ahmad, what do you think? Will this patient do better or worse with an ACL reconstruction?
So this specific patient.
This patient we saw with this root repair. Or let's say a patient with just a radial tear. Will he do better or worse with an ACL reconstruction?
I mean, you'd assume the patient to do better with an ACL recon by obviously restoring the patient's anatomy.
Yeah, not really. You're right. It's better. Let's say there's this patient with an intact ACL, and then there's a patient with an ACL reconstruction that you've done. Which patient do you think has got a better potential to have a meniscal tear that heals when you do a suture? Both have got stability.
Yeah, well, your ACL needs to be intact in order to do the repair.
Yeah. So in someone with an intact ACL, does that ACL, in the end, if you drill an ACL tunnel, it's about an 8 to 10 millimeter drill hole. into the femur and in the tibia. So you're generating a lot of blood that goes into the joint, and it basically starts to create a little clot, and the clot starts to stick, and then the clot starts to stick close to where you've repaired your meniscus, and it starts to generate some PRPs there, and then usually the meniscus tears heal better with ACL reconstruction. That's why if you don't do an ACL with the meniscus, you're still trying to drill some holes in the bone there to create some healthy bleeding to help with it. Some people actually harvest the clot, so they take venous blood from the patient and they wait until the blood is clotted. The blood is clotted, and then insert it next to the tear or in the tear, and include it in the repair. Just as a as a quick. Guys, I'm gonna just go on. Hey, you must stop me. I've got some of these cases. They become a little bit more difficult. But if you're done, if you want to finish, I think we'll probably go for another 15-20 minutes maybe, unless you guys want to go longer. John, this is a little bit more tricky. This patient here is a young patient. He's active and young, and this is my, I was a fellow, and I thought, oh man, I'm gonna have to debride this meniscus, so I just took it out. At least I took out that section that was torn. It was difficult for me to reach there, and I just kind of cut it out. What do you think? What biological, biomechanical function has he lost, and what options do you have now?
Yeah, so he's lost some meniscus. Obviously, he's going to have increased point loading. He's going to have maybe some symptoms of instability, depending on how much meniscus has gone there. He's going to have pain. And he's going to have, because of the above, he's going to have a more rapid progression towards arthritis later on in life.
Okay. So that's bad. So he basically doesn't have the same shock absorption.
Yeah.
And all those things that we initially mentioned. That meniscus does not have the same function anymore. And what's the options that we have now?
So you're alluding here to reconstruction. There's not much in the way of meniscal reconstruction. I know that people do speak about meniscal allograft transplantation.
Yeah, good.
But that's, as far as I'm aware, that's not available in South Africa, and outcomes are, it's still sort of mention it, but I don't think many people are doing it here.
Okay, so you're right. There is people that there are surgeons, and they bring in they actually ship in or fly in the transplant, and it's I'll show you just now how it looks like, but that's a good option. And what is this other thing that you see here, this patch?
Oh, it looks like a synthetic replacement. I've never heard about. I've never come across this before.
Yeah. Okay. So it's a scaffold. It's basically, there's two main different scaffolds available, and the one is a collagen meniscal implant, and it's bovine, so it's from cow. And what you need for it, you need a rim to attach it. So this rim here is what you need. If you don't have this peripheral rim anymore, it's very difficult to suture it in, because you need to place the sutures somewhere. And if you don't have almost like a punched out defect, it won't work, because it can't. You need some of the meniscal tissue to accept some of the hoop stresses. So at the moment, for various reasons, this is only available at the moment, only available in Europe. And then you've got this active fit, which is, it doesn't have cells and it's not, you know, it's not made from animal tissue, and it basically acts as a template. If you look at the microstructure, it just acts like a little scaffolded structure that cells can grow into, and then they can form tissue there. And then the other option is meniscal allograft, and it works better in the lateral meniscus than in the medial meniscus. And you can see you can't just take the meniscus and suture it in, but you have to actually take it with a piece of bone, and you have to plug it in to a defect that you create beforehand. Either you push it in, or you suture it in. And because the two roots are quite close together on a lateral meniscus, it's easier to do it with one big bone bridge. On the medial meniscus, a little bit more tricky, where you're trying to plug those roots each with a bone graft into a pre-drilled tunnel. And they often don't come like this. You actually have to create it like that. So it's quite fiddly. And then you basically, once you've got the roots attached, you still have to repair this massive meniscal, basically the peripheral meniscal repair. So it's a bigger outing, and the evidence is for the scaffolds not great. There's not a lot of big studies out, and most of the studies that are out are industry driven. For the allograft, the survival rate in a lot of the work has been done by Verdonk and his group, and he loves South Africa. He was also actually visited our department a couple of times, and the long-term survival is about 80%. That's not bad, and especially in the younger patients. So it's an acceptable option for someone that is young and you need to preserve their joint function. Okay. So it was a very difficult case, John, but you did well.
Sorry, Mike, just a question about that.
Yeah.
If those options aren't available to us as a salvage procedure, would you consider a HTO in a young patient like that?
Yeah, so for all of these meniscal and cartilage procedures, it's a very good question, Santa. For all of them, you want to look at the mechanical alignment first, and you want to adjust the mechanical alignment if the axis is off by more than 5 degrees. So if the patient has got varus or valgus, in some patients actually, even if the plumb line doesn't fall, straight smack bang in the middle, if it goes a little bit medially, they're already thinking about correcting it. So, and often the case is that people will unload the defect, especially unload the side of the defect if there is varus or valgus that is obvious, and that also makes the patient not walk on it as much, and it gives you a chance to recover and heal whatever repair or reconstruction procedure you do. But often those procedures are combined.
Okay.
Now we've got another case, and so doing arthroscopy, you've got this lesion now. It's like that actually happened to Mike and myself last Thursday. We had this case and no MRI scan. He had this ACL and posterior lateral corner injury, and then we looked and we saw a big defect in the femoral condyle. So we couldn't really plan too much. Let me just see who else is online now. Who haven't I gotten from the seniors yet? Let's see. Kirsty. Kirsty, what do you think? So basically what I would like you to tell us is, just describe this cartilage defect.
Okay, so I usually use the outer bridge classification. It looks to me, I'd like to probe it, but at least a grade 3 or 4. I think that's subchondral bone that we're seeing there. And then just estimate a size of this defect. It looks, I suppose, on the scope, probably about 2 centimeters. You might want to debride it a little bit just to define it. I think without having had an MRI, it's difficult to plan something like an OATS procedure. So you might, depending on the patient's level of activity and their sporting sort of which sport they're involved in, at the time, potentially do microfracture or come back and do a secondary procedure based on the size of the lesion. So either OATS or ACI or whatever you have available. But yeah, I mean, it's quite a large cartilage defect in a young patient. So it's certainly something that I think needs to be addressed.
Okay, so what do you make what do you base your decision on? What are the important things? You mentioned the size, the depth, the activity, and the age. And those are probably the most important factors that will make you think about the one or the other option. And then maybe the fifth factor is what do you have available in terms of your skills and in terms of your resources. So obviously most of us will be able to do a microfracture, and that will work for defects. If the defect becomes more than 4 centimeters, the microfracture doesn't work as well anymore, 4 centimeters squared. But in this defect, it might actually work quite well. But like you say, that patient, it will not have a long-lasting effect. It'll take him about 5-6 years. And after that, usually in terms of sports, their function decreases, and also the pain starts to come up again. So it's a medium-term solution, but it does carry them over. And it's a quick solution, it's a cheap solution, and you can do it in places that that are difficult to reach for other procedures. So let's just have a look at my next. Okay, so give a brief overview of your non-surgical and surgical options. We're not going to do that. Surgical options, I mentioned, so you said microfracture, OATS, you mentioned ACI. Difficult to get ACI in our patients in South Africa, whether in private or in state. And remember, ACI has got these various generations. So MACI is one of them, where it's matrix associated. And then we've got options of allograft. This is too small for allograft. And allograft is not a good graft. So basically, we're looking at microfracture or OATS for this. What are the specific people and where we know? Yeah, please. Sorry, Mike. I can't hear you. Okay, and we'll go on. So what surgical treatment options are low cost, single sitting surgery with acceptable outcomes? So you mentioned that, Kirsty?
Well, the microfracture. So you need a KY and a drill. And so I think that's probably the lowest cost. And as you've said, it does have a 5-year sort of 5 seasons of sport, whatever. So you can extend the patient's sports career, I suppose.
Yeah. And then and the OATS procedure, how expensive is that?
It's also not that expensive. I'm not sure in terms of you need to make the right plug and which company. To be honest, I haven't done one myself, but you need the patient's own tissue, so that's not the expensive part of it. It's just the sort of plug area. I'm not sure what you use, Michael. Actually, it would be interesting to hear.
Yeah, so it's a set that you use, and some of the companies have got single-use devices, and it's very expensive, and some companies have got multiple use devices. So you need to make sure that you've got a company that provides the multiple use devices.
Okay.
Like I say, if you do the microfracture or the OATS in private, they're going to give you the same money for it. So many people say, hey, should I now do like a 15-20 minute OATS procedure, or should I do a 2-minute or 3-minute microfracture here for the same money? Okay, and then here's a nice way to look at the, to kind of get your thoughts together based on the lesion. So, if they're between 2 and 4, you're looking at, the bigger the defect becomes, the more this ACI plays plays into the game. But the problem is that our availability to it is not, for us, is not there. But I think for the exams and for academic purposes, it's good to know. And we've spoken about that. The OATS is a mini arthrotomy. You can also do it arthroscopically, but you need to harvest. So if you harvest more than 4 centimeters of cartilage somewhere in the knee, then the cartilage is not there anymore on the harvest side, and you run out of, you increase your donor side mobility too much. And so if it's more than 4 centimeters, then usually there's so many bone plugs that you need to put in that you kind of move away from it. So in the larger defects, 2 to 4 centimeters, the best way to treat them is actually with this ACI.
Mike, sorry, when would you start to think in terms of a unicompartment knee replacement with a patient like this? I know the tibial component with this is not affected, but in terms of longevity and like decreased surgical time, like she's going to have a microfracture or an OATS, and she's probably going to have a follow-up procedure anyway. So she's 30. It's sort of like a borderline age. Would you consider with a large osteochondral defect like this in a 30-year-old to maybe advocate towards a uni or not?
I think let me just see. I want to show you this. So unfortunately, we have to be a little bit more creative. We can't do in a young patient, we can't do a uni knee replacement. It's not gonna be nice. So what we've tried to do, I can hear myself now. Why am I hearing myself?
We've lost your screen. I think maybe your share screen has gone onto your, I don't know what's happened.
I'm not sharing, so I'm sure someone else here is listening to my voice too loud. It's gone. It's gone. Anyway, so we don't do this anymore. I don't do I don't do arthroplasty for young patients. What we do is a mega OAT procedure, and I want to try to show you very quickly.
I mean, how long after you do that will they probably need a uni or a TK or anyway?
So they actually, this mega OAT procedure is, it works similar to an OAT, and it turns out that it's actually a very good option. We actually, let's see if I can show you there. Yeah, there. So this is a patient that has this big lesion here. Do you see that?
Yeah.
So what we do in this case is we take off his posterior condyle completely. And you can see I'm holding it here in my hand. And then we drill a hole, that's a big hole, into the femoral condyle, and then we plug it. we put that in there. So it's almost like we're trying to, you know, circumvent side mobility, where you normally harvest, you would harvest somewhere around here, you would harvest these bone plugs. We basically just harvest the posterior condyle. And obviously over time, you're worried now, what's going to happen to this posterior condyle? Well, the patient never really loads the knee in deep flexion unless they're like a ice hockey goalie, or, you know, unless they need to work in deep flexion, like a towel or bricklayer. And that's how it looks on the MRI scan. You see it kind of integrates, but you're obviously compromising because you've now taken the posterior condyles, and they get acceptable function. You know, they can jump and they can do their day-to-day without any pain. And that's basically kind of like a little shortcut that we try to do for these cases with big lesions.
Okay.
So any other questions? Must we go on one more case, or are we done? 9:30. One more case.
Can I just ask a question quickly? I've come across just using a periosteal flap. I think Spike Erasmus mentioned it for the first time I heard it, but then not much more on it since then. Do you have any thoughts or experience or feelings on just using a periosteal flap?
Yeah, so Spike does it. He loves doing it because he feels that the periosteum actually has enough growth factors and enough healing potential to generate some tissue in there, and it makes sense, you know. I wonder often with the ACI and the second generation ACI, where you harvest those cells and you inject it underneath the periosteal flap, what gives the healing? Is it the cells that you inject, or is it the periosteal flap? And what he actually does is he does scrape off some cartilage of areas where you don't need it, and he injects it underneath the periosteal flap, or he just uses the periosteal flap. These are all kind of techniques that aren't very well established, because people that write the the publications, they have access to the more sophisticated techniques. But those are all very interesting techniques, and I think for us they are, you know, the tools that we need to explore more. You know, periosteal flaps, macerated or you know, one stage cartilage injections, these mega old procedures to try to preserve the joint without, you know, going to an arthroplasty. But like I say, you're not gonna find a big amount of publications on just using periosteal flaps. What do you guys think? One more case, or are we done? Let me see what I have here. I've got I've got a young patient with osteogenesis dissecans. That's maybe a whole talk on its own. I think let's stop here. Is there any other questions? So in essence, we spoke about meniscus and cartilage. The meniscus, mainly here, the degenerative meniscus tear should be treated conservatively. With a patient that's an acute tear in a young patient, we should try to repair it and save tissue. For meniscus surgery in general, we need good ligamentous stability. So we can't do meniscus surgery in a patient that doesn't have an ACL. You need to ensure that the joint is completely stable, so that when you put a suture into the meniscus, that it doesn't tear out. There's increased healing with mirror stimulation techniques. So either with an ACL reconstruction, or if you don't do an ACL reconstruction and the ACL is actually intact, then you can still drill into the marrow to create bleeding. And this allograft and scaffolds are acceptable, but the outcomes are acceptable, but they're very expensive and difficult for us to get. For the cartilage, like we said, Santa, it's very important to have a good alignment, good stability, and if there is osteoarthritis that's already started in the joint, it does influence the management, and it does decrease the outcomes, good outcomes for restoration procedures. In essence, when the patient is young, try to repair it, reconstruct it with either microfracture or an OATS. And, you know, unfortunately, techniques like the allografts, the ACIs or MACIs, they're not available or at a very high cost to us. And if the patient is an older patient, then we're thinking about either changing the axis of the joint or to replace the joint. So that would be the nutshell of our kind of session today. Guys, you held out very nicely.